רציתי לראות שזה Good afternoon, everyone. Hey, Ron, if you're on, we'll give everyone till 1:05 p.m. And then after that, you can start.
Okay, thank you very much.
How's it going, Ron?
Adam, how are you?
You're looking very fresh.
Well, let's see, it's 8 p.m. here. I'm after a full day's work. And it's the end of the week. If I look fresh, then it's probably a miracle.
You got the Zoom thing down. You got like the bookshelf. You got a little plants.
I have, yeah, well, what do you know? I've been upgraded this last year. So now I actually have my own office, not my own desk. But you look kind of teeny tiny. Where's the camera in the ceiling?
So they gave us new offices, and so this is now like the big screen TV that's on our wall. And
look at you.
We need to do a little adjustment with the camera.
So come on, so you have comments about the bookshelf on the back. Look at yourself. You have like this.
Oh, I got nothing.
Not enough. It's a hall.
This is my lunch somewhere in here.
Oh man, how are things in New Jersey? Corona under control or still struggling?
Oh, totally under control. As in, like, our area has one of like the highest percentages, and we're still like, stay away from us. But the kids are back in school, so
that's the most important thing, right?
That's the best part.
As long as the kids are in school, life is okay.
How about you guys? You guys are like the masters of this, right?
I don't know about masters, but the numbers are coming down nicely. We actually have like a really serious academic debate whether or not children should be immunized or not. Some of the I think the majority of pediatricians say that they feel confident giving the vaccine, but there's a very considerable, respectable group of physicians and scientists that kind of counter and say, if you look at it down at the numbers, it's not really, they don't think it's worthwhile. They don't think that it's justified. They don't think that there's enough evidence to immunize children and be sure that it's safe. These numbers I don't know why they have not been published, but we had a series of children coming in with perimyocarditis after the second immunization. Now, it's only a temporal relationship, so it's not a causative thing. We don't know that the vaccine caused it, but it did happen a few days after the second vaccine. So what you should, what's riskier, getting perimyocarditis from the vaccine or getting PIMS from post-corona?
Right.
Nobody really knows. The numbers are really, really small. So
okay. And required any intervention or?
Sorry?
Did those kids require any major intervention, or they were just watching?
No, so that's the interesting thing. They all came with perimyocarditis. All of them had, normal and good cardiac function. On MRI, they had like slight edema of the heart, but they recovered. But all the PIMS children recovered as well. Nobody really knows.
What age group was that, Ron? Like, do you guys back?
So in Israel, we immunize children above 16 years old. So, and we see it at our hospital until 18. So it's 16 till 18 years.
Okay.
So that's the number. Now, we transferred the data to the Ministry of Health, and there wasn't any announcement or anything like that. So we really don't know. Maybe it's just maybe we're biased. Maybe the numbers. Nobody really knows. So so it's really, there's a heated debate on the topic. Yair Katzir that talked a few weeks ago from my department. Well, he said he's Swedish, but actually, he is Israeli. So he's one of the physicians that has actually signed a petition not to immunize. So things are very lively here in Israel.
We should definitely send a case report if there's a handful of them and get it to like the New England Journal before someone else does.
You know, we thought about it, but I think it's, we're going to cause such a, a ruckus with it. We really, I'll just stay away from that, if that's okay. It's better. I think it's safer. But anyway, guys, do you think we should start?
Yeah, Ron, thank you. Yeah, so it was a perfect segue, but that was very interesting. Well, no, this is what I actually like this, because like you get to hear, different experiences for different. But for everyone who doesn't know Ron, he's joined us all the way from Israel. So good evening, Ron. Thank you again for presenting to us, and then you can take it away.
Thank you very much. So thank you very much for the invitation. I'm very happy to have our department to talk to you today. I feel we haven't had conferences in so long. I can't remember when was the last time I saw a whole lot of you guys, which normally we meet at P2. So even if it's via Zoom, I'm happy to have the chance to talk to you. We're going to have two presentations. Dr. Karen Shachal from my department. She's has just graduated her fellowship, and she's one of our rising star attendings. Is going to take the first half an hour or 25 minutes and talk about cases of brain point of care ultrasound. And I'll follow up with discussions about procedures. So Karen, you're up.
Hold on. 1 second. Okay, can everyone see the presentation? And here.
Yeah, we can see it.
Yes, we can see it.
Okay, so hi everyone. Thank you for the opportunity to talk to you and present. I just want to say before I start that some of you may have heard about one of the cases that I'm going to talk about at the P2 Network conference a few years ago, but it's only presented here as part of a case series for the purpose of discussing the procedure. So we'll start. I have no conflicts of interest to declare. And so I'm going to present a few cases and speak about the procedure in between. So our first child is a 7-day-old full-term infant who came in for evaluation of poor feeding, and actually his referring physician sent him just to see if he's okay a day before circumcision. And when he came in, he was ill appearing, he was pale, and his vital signs showed hypothermia, tachycardia, and hypertension. Because of them, he was transferred to the resuscitation room, and on primary assessment, he had a weak hoarse cry with inspiratory stridor. His breath sounds were clear with a normal saturation, but he was pale with a delayed capillary refill time, and his glucose level was normal, his pupils were equal and reactive, and he was alert, even though he looked ill. And on examination, he had no rash. So the first interventions that were done were antibiotic treatment and a fluid bolus, obviously some warming measures. And because of the inspiratory stridor, we ordered an urgent ENT consult and a chest x-ray. So on fiber optic laryngoscopy, we saw unilateral left vocal cord paralysis, which raised a concern for a chest mass compressing the left recurrent laryngeal nerve. So a chest x-ray was ordered, and surprisingly, the chest x-ray raised a suspicion for a right pneumothorax, which wasn't really consistent with the clinical picture. So at this stage, lung and cardiac focus was performed, which ruled out the pneumothorax. And on cardiac focus, surprisingly, we saw some irregularity in cardiac contraction with bouts of bradycardia, which you can see here. 1 second. See, there's like regular contraction and then all of a sudden little bouts of bradycardia. The second infant that I'm going to talk about is a 5-week full-term infant who came in for 3 episodes of vomiting in the past few hours and some restlessness. While during triage, he was sleeping on his mother's laps and he didn't seem in any distress, and therefore he was classified non-urgent. When he came in, his vital signs were within normal, and on history taken, he was found to be a full-term uneventful pregnancy and delivery And he really came in for 3 episodes of vomiting without any fever or any trauma. He had normal stools that day. And on exam, he was crying. His fontanelle was normotensive, but on a detailed physical exam, we noticed left deviation of both eyes. Because of this, he was transferred to the resuscitation room and he was given IM midazolam, which caused a resolution of the seizure, and he had a normal gaze and tone. So the POCUS exam, which actually solved the puzzle of the diagnosis in both of these cases, is a brain POCUS. And when I looked at the literature in 2018, a UK group of radiologists published a review of the procedure and indications. And from here, you can see that the ones that are most applicable to pediatric emergency medicine are signs and symptoms of CNS disorders, such as seizures or microcephaly, and mostly the last one here, which says cases of sudden deterioration in clinical condition. And they actually have one conclusion here, which is very applicable to us. And they say in sick full-term infants and infants with neurological symptoms, you should perform cranial ultrasound at the earliest opportunity and then base the next exams by the results. And when I looked for emergency medicine studies, I saw in the same year, a pediatric emergency medicine group from the States, and some of you may be here, published a detailed review of the procedure for the purpose of hydrocephalus in this case, but I'm going to use it to go through the technique. So the first important thing is to have a calm infant use warm gel and some sucrose to relax the infant. The best transducer to use is the microconvex one, but any transducer between 5 and 15 megahertz is okay. The footprint needs to be placed in the middle of the anterior fontanelle, and it's really important to look at your depth and your gain. In terms of depth, you need to see the posterior cranial bones, and I'm going to show that in a second. And in terms of gain, overgain can falsely look like bleeding and also mask important parenchymal findings. Oh, sorry. 1 second. So we actually look at 2 sections when we scan. The first one is the coronal section, where we have the probe placed horizontally with the marker on the right. And we need to do fanning from anterior to posterior and see 3 sections at least, which is the anterior, the middle, and the posterior one. And the sagittal one, which we need to do, the marker here is placed forwards to the face, and we need to do sweeping from left midline through the right. And this is just another illustration of the sections that we want to have. This is the anterior coronal section. What's important here is to place the interhemispheric fissure in the middle, just to see that we're looking symmetrically, because we're going to be looking at differences in the ventricular size. And also in this section, we're supposed to see the orbital bones, the inferior and superior margins. In the middle coronal section, we need to see the bodies of the lateral ventricles, the corpus callosum, which kind of looks like train tracks here, and the cerebellum. And in the posterior coronal one, we need to see the atrium of the lateral ventricles here on the side, which contains the choroid plexus. And this is a scan showing from anterior to posterior, all the views that we need to be seeing. Okay. This is the parasagittal left view. What we see here is the body of the left ventricle, the thalamus here in the middle, and the parietal lobe, sorry. This one should be similar to the parasagittal right. And another view we should be seeing here is the mid-sagittal view. And here you can see the 3rd ventricle, the 4th ventricle, and the pons in the brainstem. And this is only if you have a large enough fontanelle to view everything all the way through. So here you can see it in a full scan. And what we're looking for is asymmetry between the ventricles in terms of size and in terms of echogenicity. When we need to know that intracranial bleeding looks like an echogenicity, but the same thing can look like a tumor, an abscess, and even choroid plexus. So we need to be careful when determining the diagnosis. And the same bleeding can actually cause asymmetry of the ventricles because of compression, which can be unilateral or bilateral, or obstruction to CSF flow. Okay, so when we have hydrocephalus, it starts with some ballooning of the anterior horn of the lateral ventricles, and it continues to be an enlargement of the frontal horn, what the radiologists call Mickey Mouse ears, which you can see here. Another thing you see in the middle section is you see the temporal horns of the lateral ventricles, which we're not supposed to be seeing in a normal infant in this view. And in the sagittal plane, you can see major dilatation and the chord plexus, which is dangling down here. There is a measurement we can make. It's mainly for the radiologist, but we can use it if we need to. So it's called the bifrontal index. And what you do is you take the widest part of the anterior horns of the lateral ventricles and you divide it by the widest inner table of the skull. And if this relationship is greater than 0.5, it correlates to hydrocephalus. And here you can see a full scan of hydrocephalus with the Mickey Mouse ears, which I talked about. Okay, so let's go back to our infants. The first one, who was a 7-day-old and was pale and ill-appearing, he had hypothermia, hypertension, and bouts of bradycardia, unilateral vocal cord paralysis, and on history taken, he was found to have a vacuum delivery, and he also failed his hearing screen on the right. This is his brain focus. You can see dilatation of the lateral and the third ventricles with areas of hyperechogenicity within them and within the brain parenchyma, which led us to suspect hydrocephalus secondary to an acute bleed. This is his CT scan, which shows bleeding in the occipital lobe with severe pressure on the brainstem with ventricle dilatation. And at the same time he had the CT scan, the lab called to say that as his PTT is prolonged 3 times above normal, and later on his factor VIII levels came back undetectable, which confirmed the diagnosis of hemophilia A. And he is over 2 years old today and has normal growth and development, and he receives weekly subcutaneous emicizumab, which is the factor VIII mimicker treatment. Our second infant was the 5-week-old who came in for 3 episodes of vomiting, and he had the gaze deviation to the left, which was resolved with a dose of midazolam. So this is his brain focus. What you can see is asymmetry of the bodies of the ventricles, which is mainly what we're supposed to be looking for, with compression of the right lateral ventricle, and the echogenicity here represents bleeding. This is the sagittal view, and if it's a little fast, but you can see the echogenicity here, which is a massive bleeding. This is a CT scan, which shows blood in the left thalamus, which bursts into the lateral ventricles and dilates the left lateral ventricle. The bleeding continued through the third and the fourth ventricles and caused the beginning of secondary hydrocephalus. This is without contrast, and when contrast was added and he had a CTA, the CTA was normal. This infant is today without seizures. He's treated with Keppra. And the reason for his spontaneous bleeding is undiscovered, even after his radiologic and hematologic workup. So now that we know how to perform a brain focus, I want to talk about the third case, which is a 5-week-old full-term infant who was referred for a single episode of vomiting and drowsiness, but he came in unresponsive with normal vital signs. His primary assessment was generally normal besides the neurologic one, which showed epistatinus, I'm sorry, I have no idea how to say that word, and a full fontanelle. So these 2 findings led us to very quickly perform a POCUS exam, and this is it. And you can see the echogenicity, which is not only where the chord plexus is supposed to be located in the sagittal scan, but all through the body of the lateral ventricle, and also here in the coronal section. So he was treated with antibiotics and hypertonic saline. He had a rapid sequence intubation and he was taken to an urgent CT. This is his CT without contrast, showing an intraventricular bleed involving the lateral ventricles, the third and the fourth ventricle with dilatation secondary to that. And when you added contrast, he had an AVM at the height of the left thalamus. And it's important to say that the most common presentation of an AVM is intracerebral hemorrhage. But the bleeding of the AVM can compress the ventricles and cause asymmetry. And sometimes, like here, we can actually see the bleeding itself as an echogenicity. So from the time this infant came in to the time he was at the OR for bilateral ventriculostomy, took 45 minutes. And he is now 4 months old with a normal EEG, no seizures, and normal development with only mild right arm weakness. So we talked about the nice things about brain focus, but it's important to talk about the pitfalls. It's really important that the fontanelle size is large enough. And also you should remember that with age, the skull grows and we may miss the lateral and distal parts, which are the most important, like the occipital horns, the posterior fossa, and the third ventricle. It's also important to know that mild asymmetry, which is less than 5 millimeters, could be meaningless, especially if the triangular shape of the bodies of the ventricles is still the same, is normal. And like I said, that bleeding looks the same as a tumor, an abscess, and even choroid plexus. So it's important to be careful when we make a diagnosis. And in a child with a VP shunt, non-dilated ventricles don't rule out shunt malfunction. And another important thing I want to say is that the ultrasound has not been proven sensitive enough for extraaxial bleeds. I'm going to talk about that a little bit. So when we have extraaxial bleeding, like a subdural or an epidural hematoma, the most important thing we need to look for in focus is to assess a midline shift and to try to see if the cortex is moved away from the skull. And I'm going to show that in a second. So a CT or an MRI is actually preferred for extraaxial hemorrhage. So here, when I looked at the literature again, there was in 2017, there was a group of pediatric emergency medicine physicians from California who, again, some of you may be here, who published a pilot study discussing focus for intracranial hemorrhage. The study was prospective and they took children under 2 years old with intracranial hemorrhage on CT and 2 controls for each one. And a pediatric emergency medicine attending performed a focus exam, and then 2 blinded pediatric emergency medicine attendings looked at the exams, and they needed to say if there is bleeding or if there's not. So they had 12 patients, 4 of them had intracranial hemorrhage, and all of it was extraaxial, which is very important because we said that brain focus is not sensitive enough for that. One of them identified all 12 correctly, and the other had 2 false negatives and 1 false positive. And here they show an example of a subdural hemorrhage, and it's very obvious on CT, but look, in the ultrasound, you can only see that the brain parenchyma actually moves away from the skull. So a similar group from California in 2018, also in pediatric emergency care, they took a step forward and they tried to see if cranial ultrasound, this time performed by pediatric radiologists, is well enough to be a screening tool to rule out intracranial hemorrhage. So this was a retrospective study of children under 2 years old who had a cranial ultrasound for suspected intracranial hemorrhage. And who did the ultrasound was a pediatric radiologist with neuroradiology training. And they divided the bleeding to significant, which is moderate or large, or if it caused clinical symptoms that are critical. They had 285 ultrasound exams and 35 bleeds. 27 of them were significant. And it's important to say that from the 13 that were missed, 8 were subdural. As you can see, the sensitivity of ultrasound, even by a pediatric radiologist, was not good enough for intracranial hemorrhage in this study. And this is actually their conclusion, but they do say that it should be considered in situations where you can't obtain advanced imaging, either because of availability or because of the patient condition, which is actually similar to the cases I presented. So in conclusion, I think we should use brain focus to rule in at this stage and not to rule out, because from what we know so far, it's not sensitive enough. But as you could see in the 2 cases and 3 cases I presented, it can hasten the diagnosis, the transfer to CT, and even the transfer to OR. And it takes less than a minute to put on the probe and take a look, and it doesn't interfere with treatment simultaneously. So I think it's worthwhile. Thanks.
Thank you for those. There was a question in the group chat in terms of why the blood clots look so hyperechoic. Any idea?
Well, Karen, do you have an idea, or should I try to guess?
I think maybe the gain, maybe there was a little bit of overgain in the studies.
My guess would be that, it's probably it's the density is higher, and it's higher than the fluid around it, maybe. And maybe that would cause a bit of more contrast. I don't think it's going to be as dense as a bone. but definitely with the blood around it, so that might cause a bit of stereoacoustic enhancement, maybe a bit of and it by itself is a bit more dense. So that would be my guess. If anybody else has a better educated guess, feel free to help us.
It's actually interesting because the subdural hemorrhage isn't hyperechogenic. It was shown just as a space. So it's an interesting question.
Any other questions? Okay. Henry, should we move on to second presentation?
Okay. I don't think Dr. Oglecat, are you ready to present?
No, I'm talking about our other half.
Sorry. Yes, I completely forgot. Yes, you can completely move on.
No, don't worry. We're still going to fill that almost all of the hour. Okay.
No, that's okay. So, yeah, completely forgot. Yeah, sorry about that.
No worries. Okay, so let's see if you can see my screen. Do everybody see my presentation? Is that okay?
Yeah.
Okay, cool. So I'll be talking about POCUS guided procedures. And like I said already,
Ron, your screen is not selected. You should do advanced sharing again. Yeah.
Sorry about that. Hold on just for a sec. There we go. Now we got it. Now it's probably okay, right?
Right.
Okay, thank you. Thank you for that. So like I said, Dr. Yair Katzir a few weeks ago talked about nerve blocks in the emergency department. And, as Yair is part of our group, nerve blocks, the numbers of them have actually been rising in our department in the last few months. So I'll show you at the end, I'll show you a bit of other nerve blocks, some that maybe Yair did not talk about, but we'll try to show you and demonstrate a bit of the other procedures that we use point of care ultrasound for. Just for disclosure, there we go. I give consulting services to GE, but nothing that I'm going to say today is relevant to whatever consulting that I do, and obviously I take full responsibility for everything I say. So let's start with a case. A 2-year-old coming in with 6 days of fever, 24 hours. The last 24 hours, she stopped walking and she started crawling around the house. She did not have any history of trauma. She was a normal toddler, fully immunized. And because of these complaints, the parents brought her to the emergency department. On physical exam, the treating physician noticed that she had limitation of the left hip rotation, mainly in internal rotation of the left hip. All the rest of the exam was normal. Her abdomen was soft, it was not tender. All the other joints were, with no limitation in movement and no pain, and on palpating, the limbs, there was no point tenderness. So to continue investigation, the treating physician thought, and he said, I'll try and using an ultrasound, and let's see if this child has an effusion within her hip joint. Mainly concerned about the possibility of a septic hip. Now, if we're going to talk a bit, just for a short recap about septic hips. So septic joints may be seen at all ages and all age groups, but it's most common in children less than 3 years of age. And the most common joints are the lower limbs, when the knee is probably the one with the highest frequency of infections. It was the highest risk of infection, but the hip is, a very close second. So how do we come to the diagnosis? The diagnosis is a combination, right, of the physical examination, of laboratory studies, microbiological cultures, which usually need to be taken from within the hip joint. And to do that, we need some imaging studies. And the most important study for us would be obviously the ultrasound. Now, what is the technique? So initially we place the transducer in a bit of an oblique fashion over the inguinal ligament. And what we see is we demonstrate the head of the femur. So you can see here, this is the head of the femur in a transverse plane. And then on that spot, we rotate the transducer with a probe marker towards the umbilicus, and then we can see the hip joint on its long axis. So what we can see here, and we have here another image with some captions. So you can see the femoral head, you can see the femoral neck, you can even see the physis. You can see the capsule, and when you have an effusion, I'm going to try to highlight it for you. When you have an effusion, so you can see this black area here, the capsule is kind of elevated, and that is your effusion. Now, the way to proceed is having a hip arthrocentesis, and it's an urgent procedure because we want to decrease cartilage damage. And this is usually done by orthopedic surgeons. Now, all of this requires a lot of coordination between different teams, right? The emergency department and the orthopedic surgeons to come and perform the arthrocentesis. In days past, when we didn't even perform sedation or point of care ultrasound, then you needed even the anesthesiologist, you needed a radiology. It was like a major operation to get everybody in the same room at the same time. Again, just to remind us, this is how effusion looks like. You can see the black here, and this is a normal hip. Okay, so you can see the soft tissue in the capsule kind of go down and accompany the cortex of the bone. So what we started doing in our department, in I'd say the last 2 years, is that when we have children that need to have a hip arthrocentesis, we perform everything together. So our emergency department team, they obviously perform sedation, ultrasound, and they also perform the tap itself. And it looks something like this. So you can see here, this is Dr. Prokachimer from our department. And you can see here, this is the needle coming into the effusion. And if you look here, you can see the effusion, and you can actually see her drain it, and woof, all the fluid goes away right here. And we actually, since we started doing it, and this started like many things, it started just because we didn't have any other option, because the first case happened when we were waiting for the orthopedic surgeons for hours and hours, and when they did not come, we just asked them, hey guys, would you mind if we just did the tap, thinking that if we are able to, if we feel confident in bringing the needle to whatever point on the screen that we see, how much of a difference it's going to be, from performing a nerve block to drain some fluid. And since the orthopedic surgeons, they were so swamped, they said, yeah, sure, just go ahead. And that's how we started. And then we kind of gathered the data, and we actually came up, and this is still unpublished, and we're going to send it for publication. But we gathered cases where we performed the arthrocentesis as opposed to the orthopedic surgeons. So just looking epidemiologically at the two groups, so you can see that there is really not a big difference in the characteristics of the two groups. You have 10 kids that had their hips tapped by the emergency physician team, and 22 children that the orthopedic surgeons were the one that performed the procedure. And when we compared the groups, you can see that the time to diagnosis was like about a third between us and the orthopedic surgeons. And we call time to diagnosis when you actually tapped the hip and you saw pus coming out. And because the time to diagnosis was much faster, obviously the time to antibiotics was much faster, because we started treatment right away. Another interesting thing is that the vast majority of them had only ultrasounds performed in the emergency department, and they did not need a radiology for confirmation. But if you look here at the third line, the post-procedure hospital stay was shorter for the children that had their hips tapped in the emergency department, but it was not statistically significant. I think that just because our groups were too small and we didn't have enough power, that's why we did not have statistical significance. But if we're going to try to follow up, and if we're going to try to have, to continue the study with a larger group of patients, my guess is that it would actually also influence the length of stay within the hospital. So just to conclude, we saw in our study that children undergoing PEM hip aspirations had shorter times to diagnosis and treatment, reduced hospital resource utilization for sure, because it was just us and we did not need radiology and orthopedic surgeons as well. And while not statistically significant, they did have a shorter length of hospitalization. Further studies are needed to actually confirm and improve that that this was actually the difference is significant. But still, I'm still hopeful that that the numbers, with the greater numbers, will find that statistical significance. If we'll try to move on, this is another case.
Hey, Ron, I have one quick question.
Yeah, no, for sure. Yeah, go ahead.
All right, thank you. Did ortho ever, do they go back into that hip and wash it out in the OR? Or did they ask you if you're going in to do any washing out when you're doing your aspiration?
So what happened? So for us, ortho, if the child is recovering, they don't go in. They don't do another tap and they don't go to the OR. But after I think like the third or fourth case that I tapped a hip, I actually called the head of orthopedics here and I said, since I'm performing the taps and I know that your orthopedic surgeons, you wash the joint when you do it. What do you think? Should I also, wash the joint? And he said, yeah, sure. If you're already there, so I started, washing the fluid, the joint myself. And it's, the needle is already there and it's not really that difficult. And I make sure that I drain all the fluid that I put in. And so now we not only we tap it, we also wash it, and really the orthopedic surgeons are happy with us doing it, and so that's what we do, concerning the washing the joint. Any other questions?
Ron, really quickly, I don't know if I missed it. How do you do the anesthesia? Like, do you do lido, or are you doing it under sedation?
No. So this needs sedation because usually the children, like I said, the majority are less than 3 years of age, and even if they're a bit older, they're in a lot of pain. And just I didn't go into it, but just the whole placing the child and getting him set for the tap. If they're not sedated, they find it really uncomfortable, because what we do, I kind of put a towel underneath their buttocks because I want to kind of elevate their, all of their the hip and the pelvis. It's specifically important in the younger children, if they're a bit chubby, because otherwise you kind of get stuck between, and the thigh, which is has its fat pad, and the abdomen, and you really need like a more flat surface for that. And just placing the towel underneath their buttocks and elevating it, that's really uncomfortable. And then you really need the child, since you're tapping it, you really need him not to move. So we sedate them, we give them ketamine. And with ketamine, I mean, they're fine, they're not in any pain, and they're not moving. And we find that that's the optimal way to do the tap. I hope that answers the question.
Yeah, no, it does. And then approximately how long does the process take you from the patients you did?
Well, the first one took me about, 20, 25 minutes. The last one took me about, I'd say 10 altogether, because, once you feel more comfortable with it, then it's, with a bit of practice, it's things are much more fluent. So yeah.
No, that's great.
Any other questions? And I didn't say that, but we're Israelis. Feel free to shout out and say whatever you want anytime. Okay, we're not insulted. Moving on. This is a case of a child that a 3-year-old that initially was seen at another hospital, an outside hospital, and he was admitted there for pleural pneumonia. So he had a big parapneumonic effusion. He was treated there with antibiotics for 9 days. with IV ceftriaxone, and was discharged with oral amoxicillin and cephalexin. Now, when he presented at our hospital, he came back with a chief complaint that there was a suspicion of recurrent effusion. So he had his x-ray done in the community, and they said that they thought that he has, again, an effusion, and they were concerned about whether he had a bit of a shift of the mediastinum, and they sent him to us. When he came to us on physical exam, his vital signs were pretty much normal. He did not even have fever. His heart rate was 98, blood pressure 18/70, and he sat at 100 in room air. But when on auscultation, he really had decreased air entry to the left lung. We saw the X-ray. I don't have it here, unfortunately, because it was done outside of the hospital. But it was like it really raises suspicion that there is an effusion there. And when we performed an ultrasound, I think all of you can see for yourselves that he definitely had an effusion, and it looked kind of gross with all that things floating in there. So really, we had it looked like he had empyema and recurrence of the effusion. So we sedated the child, and at our department we don't really have invasive radiology, so we put in our own chest tubes, and so we sedated him, and then we thought maybe since it looked kind of like there was a lot of things floating there, we thought maybe we'll try to perform it under ultrasound and just make sure that while we're draining the fluid, we're not hitting anything else, and that we're draining it properly. So, and again, I apologize that the image comes and goes because the child, obviously was breathing. So it kind of slid, but you can see here the needle going into the pleural effusion. And then the physician started draining, and in the middle, you can see that the needle kind of went back a little. Okay. And you can see the needle went back a little, and the physician performing the procedure said, okay, I think I drained it all. And there you see it kind of went back, and he didn't have any more fluid come back. And we actually told him, we saw that, you accidentally pulled back your needle. You need to move forward again. And once, when he pushed back in there, you can see him pushing it back again, fluid came back again. So even though, I'm pretty sure that we could have done it blind, and we, just, marked the diaphragm and tapped above it. But even having the ability to watch the drainage of the fluid of the effusion during the process, we were able to correct the physician performing the procedure and guide him to, you need to push your needle a bit further and just to make sure that that enough fluid is drained. The child had a pigtail drain, you can see it here, and about 150 cc's of cirrhotic fluid was drained. I was treated with cefuroxime and clindamycin for another about 11 days. They removed the drain after 3 days, and after that, he was discharged back home. So that's another example of a procedure that we use POCUS to guide us with. Any questions about that? Okay, moving along. Foreign bodies, we all have these cases, right? So a child was walking barefoot, obviously, in her backyard, and she felt that something stabbed her, and they saw like this small wooden stick, and the parents took it out and said, yeah, you're okay. But and she's 13 years old, and 5 weeks later, she's still not stepping on her leg, although the parents removed that piece of wood, and she's not really bearing weight on the foot, and she feels like she has something stuck in there. And so an X-ray was performed, and I think it's pretty easy to see that stick there. But there was a concern because the parents already took out that that wooden thing, or they thought they took it out. But when we came to take it out, they said, okay, but how are you going to be certain that nothing is still stuck in her leg? And what we did is, obviously, we did an ultrasound, and you can see here, and this is just in the loop, so you see the wooden stick, and you can see actually how our orthopedic surgeon kind of yanks it out, and this is what came out. He was very happy with himself, obviously, and we could verify under ultrasound during the procedure that nothing actually stayed back in the foot. So some more procedures. Again, so Yair Katsir talked about, so you see here an abscess being drained, and you see here all kind of nerve blocks. Yair talked about a case about a child needing sutures in his palm, and here you can see an ulnar nerve block. And after that nerve block, the child did not need any more sedation, and did not need sedation for the suturing, and just with that regional nerve block. It went well. We at our hospital, in my department, we don't have fluoroscopy within the emergency department, and the orthopedic surgeons actually find it very, very reassuring when they perform reductions to do a before and after ultrasound, and you can see how before you saw kind of this big difference between the two sides, and after it looks aligned pretty well. Another case, again, going back to the block. So we had a child, and this was, I think, 2 months ago. A 7-year-old had a fall on an outstretched hand from a swing, and he fell on his right arm. He had a right forearm deformity with mid-shaft tenderness. This is a 7-year-old, to remind you. And this is actually a picture of what Dr. Karen Shachal, who spoke earlier, what she performed. So you can see here, this is the brachial plexus. So this is a subclavian artery, the first rib, and the plexus itself. And the child was very cooperative, and you can see here the needle going in, and you can see Karen injecting all around the brachial plexus. And with and this is something that is not as common. I think the adults do it much more than we do, and I think what we learned from these cases that we probably should do it much more. And with this block, the child was very comfortable, did not have any pain. And again, when the orthopedic surgeons came for the fracture reduction, the child did not need any sedation, and he was pain-free, and everything just moved on so much quicker. Because of he did not need that sedation. So so that was that's very useful. And I tried to look for some literature about it, and specifically about supraclavicular brachial plexus blocks in children. And all I found were just a bunch of articles from anesthesiology about them performing it before surgeries for pain control. I did not find any literature from our groups, from the pediatric emergency department, and I think this is if we're going to be able to gain have more and more cases like this, this is actually an interesting topic to try to see and demonstrate the utility of it. Now, I thought that I'm going to finish my presentation with this case, and Adam and Dave, me. I finished preparing this about like a couple of hours ago, and I had a couple of hours in my department, and I said, okay, I'll just walk around and see what's happening. And as I was walking around, I saw this. So this is an image. You can see here the date, so that that I'm not pulling your leg or anything. So this is the 22nd of April. In Israel we do it the other way around. 6 p.m. That's what is it? It's like 11 a.m. for you guys. And a 3.5-year-old came into our department with a contusion to the right femur because he was jumping on a trampoline, and his friend or brother or whoever landed on his leg. And you can see this really nasty fracture in the femur. And I came and I saw this child, and he was ready. He got fentanyl, but it was already like an hour after that, and the pain was coming back, and he was all drenched in sweat because of the pain. And I had like a free hour, and I asked the parents, would it be okay if we performed a regional nerve block to control the pain? Parents, they agreed. So here you can see me, and again, this is the time. Okay, so it's like what is it, by 12 noon for you guys. So you can see here the femoral artery, femoral nerve. You can see the femoral artery and vein, and you can see the nerve. And you can see here, I'm coming up, I apologize, you don't see the needle all the time, but you can see me coming in. And initially I put some fluid there, and then I went a bit too deep, and you can see me injecting into the muscle. So I pulled back a bit, and then I was right underneath the fascial iliac plane, and here you can see me kind of how the fluid really separates the fascia and fills that potential space. And here again, I'm giving him a bit more of a bupivacaine. And I went later, 5 minutes later, I went back to the child. He was lying in his bed. He was actually tapping on his broken leg. He wanted to show me, say, hey, I have here, look, they put like a bandage over it. So it was really effective, worked really well. Another demonstration of how regional nerve blocks and, even a bit more of, our traditional just, radial, ulnar, and median, how they're very effective and really help us with the, pain control and, just really promoting care for the children. Thank you very much for your attention. Like I said, it's a pleasure talking to this group. If you have any questions or comments, I'd be happy to answer.
Thank you, Ron. That was great. I think the group from Switzerland will be publishing something on the supraclavicular blocks. They presented that, I think it was like 1 or 2 months ago. So something to look. Yeah, but great cases. And, I wish I had the same guts as you to do the aspiration and the wash out the hip joint. So,
well, it's fun. Yeah, a lot of the things that we do, it's just because at the end of the day, if you don't have a choice, you just do them. So I remember, for us, we have ophthalmology 24/7, and so for us looking at the with an ophthalmoscope, looking at the retina. We don't need it so much because it's really convenient. We have them there. I know that other centers, they don't have them. And so they trained and know how to do it. Centers that don't have orthopedic surgeons available. So the team there learns how to do the fracture reductions themselves because, somebody needs to take care of the child. For us, in that instance, we did not have orthopedic surgeons available to tap the hip and, and for a septic hip, time really makes a difference if you want to increase your chances of the child not having limping in the future. So we just it's not was it ideal? Would it be better if the orthopedic surgeons did it? Maybe, but we didn't have a choice, and we had to learn how to do it. So we started doing it, and at the end of the day, I think the children are getting better care for it.
Yeah, that's awesome. So yeah, thanks again for presenting, and look forward to reading those the case series you'll be presenting.
Sure, thank you.
Dr. Brown, I had a question about the local regional blocks. Do you find that the time in terms of reducing the fracture and all of that between that and once you do the regional nerve block versus not, does it decrease the time for orthopedic surgery to take care of the reduction? Or do you find that moderate sedation is enough, or do you now do all of the regional blocks all the time on those kids?
Well, I think there are a couple of things to consider when thinking about sedation versus regional nerve blocks. First of all, is that if you look at the time from beginning of procedure till the end, then I do believe that the time would be shorter with a regional nerve block because you don't have all the time for the child to wake up, and you don't have the side effects of sedation. So many times they start vomiting, they're not well, and you're waiting for them to really wake up and be able to go home. Another consideration is, and one of my colleagues from SickKids started publishing about it. We use ketamine a lot. I think that would be probably one of the more common drugs for sedation. But ketamine is not water, and ketamine has its side effects. And he actually demonstrated. His name is Yaron Finkelstein from SickKids. He actually demonstrated that ketamine has effects on the cellular level. And I can't repeat all the all the things that he found, but he had like higher levels of markers that are compatible with brain injury after injecting ketamine, higher and things that erase concerns of maybe you have a higher frequency of ADHD after use of ketamine. So if we're able to perform a regional nerve block, get the same good results in controlling the pain, shorter duration of staying in the hospital, and and maybe eliminate the chances of some kind of side effects. I think I'd probably lean towards having the regional nerve blocks.
Is that something that you do on a regular basis? Is that something that's protocolized now at Schneider's in Israel, or that's something that's dependent on whoever is on?
So, I can talk about my department, and in my department, I really give credit to Yair, who really is promoting it. So, when I was at Sick Kids, I was trained on performing blocks as well. But when I came back, I didn't push it ahead as much as Yair did. And when Yair came back to us from Stockholm, and he's really, being a champion of it, and he caused us all to be really enthusiastic about it, and so our numbers now are increasing more and more. And so, and it's suddenly, our toolkit has it's bigger, and we have another option. And once you have another thing, you think about it more, and the more we think about it, it's more that we're aware of it, the more we use it.
Thank you.
Okay. Okay, guys, thank you very much. It was really a pleasure talking to you.
Yeah, great, Rhonda. Great. Thank you again for presenting. So glad you were able to make time for us, and then hopefully looking forward to hear more about your cases. So hopefully we'll have you back again in a few months.
We'll be happy to.
Yep. Okay, and as everyone is aware from the email I sent, this week we have the opportunity to have 2 lectures. So we're going to start around 2 p.m. as Matt from Cohen Children's invited Dr. Kat Ogle to present. So we'll be starting around 2. Matt will be jumping in and doing the formal introduction. So if you guys want to hang on for a little bit. But once again, thank you everyone for attending.
All right, it's just about 2 o'clock, so I wanted to take the opportunity to once again thank Dr. Ogle for joining us. We at Cohen's invited her to join us for our weekly POCUS didactics. Looking at POCUS from a little bit of a different perspective was our goal, and what we asked her to talk about was the use of POCUS in mass casualty incidents. Dr. Ogle is faculty at GW in DC. In addition to point of care ultrasound, she is a master educator and is involved in ultrasound education at all levels, from fellowship all the way down to medical students. So we are very excited to hear this talk. Thank you again for joining us.
Thank you so much for having me. Can everyone hear me okay? Can I get some emojis?
Yep.
Okay, great. It's so hard when you're in the Zoom environment to know whether or not people are engaged. So thank you again for having me. I really appreciate this opportunity, and I look forward to chatting with you about it. So as Dr. Solomon said, I'm at George Washington University in Washington, DC. So I am an adult ER doctor, and so I don't actually use POCUS much on kids, with the exception of when we do some collaborations with Children's National for education. So if there are departures from your real life, I welcome feedback, and I look forward to chatting with you. So I don't have any financial disclosures. And I do want to take a moment to acknowledge that this is going to dive into some brief discussions about violence on a large scale. Some of us have had situations in which we've taken care of patients like this, and it can be emotionally challenging and have had long-term emotional ramifications. In addition to that, this has been a really stressful year. And so I just want to acknowledge and make some space for folks. If you're feeling triggered, just take care of yourself first. It's a really important thing to do. The scenario that I'm about to present to you is purely fictional. So any sort of similarities to real life events are just by happenstance. This is not a real scenario, but it is derived from real events. So you're on shift, it's the middle of the day, you're enjoying kind of a lull in activity, and one of your colleagues pulls up Twitter and sees a post from NYPD that says there were shots fired at Erwin Altman Middle School. Officers are on the scene, avoid the area, and shelter in place. So you're feeling a little bit anxious, and then the next thing you know, the radio pipes up and says EMS to CCMC. This is CCMC, go ahead. We're en route to your facility with multiple GSWs. And you pause for a moment and you say, wait a minute, are you coming to the right place? Yes, there's a school shooting and there are multiple patients from 11 to 13 years of age. We anticipate about 15 casualties. Okay, here we go. So you get your team together, you pull everybody together, you get your charge nurse, you sort of talk to your nursing supervisor, you activate your trauma team, and then you move into operations. So you start getting your rooms ready. So you line up all of your equipment, you make sure that you have all of your personnel, everybody is ready to roll. The next thing you know, you hear sirens. So your first couple of patients come in, and these patients are severely injured. They have penetrating trauma to their chest and abdomen. Your first FAST exam shows the pericardial effusion. Your second FAST exam has a pneumothorax and a positive FAST, and your third has a positive FAST and a hemothorax. Your teams are rapidly addressing these patients. They're instituting your transfusion protocols and ultimately find that these patients have devastating intrathoracic and intra-abdominal injuries. Now, 5 minutes later, there are more ambulances coming in. So things are getting a little bit frantic in the department. Things are getting a little bit noisy. You start to have a lot more people. You start to have a lot of kids crying. People are yelling things around. Then patients start to arrive by private vehicle and by police cars. They're no longer being brought in by ambulance. They're being brought in by police who are at the scene, who are frantic to get these kids someplace where they can be taken care of. So you have even more people in the department. Things are starting to move so quickly and so crowdedly that it's difficult to get around. If you have cart-based ultrasound machines, you're trying to get your FAST exams done. However, you can't get the machines around the stretchers. and you've got sounds of kids crying, you've got alarms beeping. You're hitting the limits of your department. Then private vehicles start bringing patients. They're in the ambo bay, they're honking, the tires are screeching, and you are at the brink, you're bursting at the seams. The noises are untenable. It is difficult to communicate with your colleagues. It is difficult to know what is going on. You're beginning to run out of equipment. You're running out of gauze. You're running out of blood. You're running out of fluids. Folks are really strained. Then more ambulances come. And at 2:55, you have reached the ultimate capacity for your system. Still very noisy. This is typically what happens in a mass casualty scenario. So in a matter of 42 minutes, you had 38 patients. So I want to pause just for a moment, because I know that everyone has different protocols for mass casualty and disaster response. And I just want to ask folks in general, how many ultrasound machines do you have in each of your departments?
We have 2 machines.
We have 3.
2.
So I derived this case from the Orlando Pulse nightclub shooting. All right. In the Orlando Pulse nightclub shooting, they had 38 patients in their first 42 minutes. And, you know, as you can imagine, their teams were overwhelmed, but it was not 2 o'clock in the afternoon, it was 2 o'clock in the morning. And I chose the middle school that I listed there because that's a couple of blocks away from your main site at Cohen Children's. Because I want to sort of highlight that proximity to a trauma center may significantly impact the number of patients that you get in a certain time period. And again, the noises and whatnot are just sort of to initially give you a little bit of an adrenaline rush to sort of think about what this is going to be like. Now, for the most part, I think you all can agree that there's limited utility to doing fast exams in pediatric patients in blunt trauma. But I think this is one of the scenarios when you have penetrating trauma that you could potentially use your fast exam. And, you know, for our cart-based systems, particularly when your ED is overwhelmed with volume, it can be difficult to get those cart-based systems around. So this is a scenario in which sometimes those handheld units would be much more useful and efficacious to diagnose patients on the fly. So it's really about your EFAST when it comes to your initial trauma response and using ultrasound. So this is a map showing how close the middle school is to you all at Cohen Children's. And now I've never been to this part of New York, so I don't know how busy those streets are and what the sort of flow is and whether or not they're one-way streets and whatnot. But I can imagine that people probably would come to you first rather than going to other hospitals, particularly if they were on foot or if they were coming by private vehicle. So when we think about mass casualty, the definition is really that we are exceeding the limits of our system. And this comes from a perspective of equipment, this comes from a perspective of staff, and it has the potential to negatively impact patient care and certainly to eat up our resources. So for a visual, this is really what it looks like. You're filling up, and then you're completely overloaded and you're sort of seeping at the edges. So much of what we've learned in the adult world about sort of the mass casualty response comes from real life events. And another incident which did involve some pediatric patients was the Boston Marathon bombing. So in this scenario, there were 9 children. One of them was a 2-year-old boy, one was a 9-year-old girl, one was a 14-year-old boy, a 10-year-old girl, And the injuries varied from having just simple head injuries to fractures to penetrating injury from ballistics. And, while there were not a whole lot of injuries to the thorax and the abdomen in Boston, you can imagine that with those ballistic fragments from a bomb, you could certainly have that scenario happen with your pediatric patients. And then, as I said, I pulled some of this data from the Pulse nightclub shooting and what happened there. And ultimately, at the Pulse nightclub shooting, there were 49 killed and 58 wounded. And 49 victims included SWAT team member, and 9 of those patients succumbed to their wounds, but the rest of them actually survived. And so Orlando's response and the way they organized their patients and the way they organized the use of imaging and ultrasound at the bedside really was efficacious to improve the outcomes for these patients. Oh, I don't know what happened there. Get a restart. So when we think about how this intersects with PEM ultrasound, you have your natural disasters, you have your terrorist attacks, and you have your mass shootings. I'm not really going to talk about natural disasters because most of the time when you're dealing with natural disasters, you're not dealing with penetrating injury. And again, I think that for PEM ultrasound in mass casualty incidents, the blunt injuries are probably not actually going to be helped that much by ultrasound. But when we talk about penetrating injury, which you can see more often with terrorist attacks and mass shootings, then I think it does have some utility. So in a terrorist attack, you have 2 different types of injuries. You have your penetrating injuries, but you also have your blast injuries. Penetrating injuries is pretty simple. If you have a penetrating injury to the thorax, you're obviously at risk for cardiovascular or pulmonary injury. Now with your blast injuries, don't forget that this impacts any of your viscous organs. So you can develop a pneumothorax, you can actually rupture any of your hollow viscus. And don't forget that you also have your quaternary injuries. So if someone gets blown by the blast off of a high elevation, then you have to sort of consider their fall as a manifestation of their problems as well. Again, those blunt injuries, probably less important in the pediatric population, but certainly having a hollow viscus injury or a pneumothorax can be diagnosed by POCUS. For your mass shootings, again, we're really looking at penetrating trauma and crush injury from sort of trampling, but we're probably not going to be using POCUS much for the crush injuries. So when we think about EFAST, I'm going to go on the assumption that all of y'all know how to do an EFAST exam, but I just want to pull up some pictures really quick. So EFAST, your right upper quadrant is in the mid-axillary line at the intersection of the subxiphoid line. Your subxiphoid is obviously underneath the xiphoid process aiming up towards the heart. Your left upper quadrant is going to be intersecting with the subxiphoid line and the posterior axillary line. And then your pelvis is, of course, just above the symphysis pubis. Now, when you're talking about the E portion of your FAST exam, it's really important with your supine patients to make sure that you are going more anterior on the chest. Some folks have mistakenly taken their ultrasound probes a little bit too high up to the apices, sort of thinking that that's where a pneumothorax is likely to be. But if you truly think about where your supine patient lies and where the air will be in their chest, you really need to be more close to the nipple line when you do the thorax assessment on these patients. So what do you all see on the image on the right-hand side? Is the video playing?
It looks like possibly liver, and above the liver is a diaphragm, but I don't think I see a positive spine sign, so I don't think there's fluid above there.
Okay, I agree with you. There's no fluid above the diaphragm. So you've got your diaphragm here, right? And then this looks like healthy lung. You've got your nice mirror image artifact. You've got a sort of dense shadow there. Now, if you look up here at the top of the liver, there's actually a sliver of free fluid here. And then if you follow it around over here, you can also see a little bit of free fluid between the kidney and the liver in the hepatorenal recess. So if this were a penetrating injury to the abdomen, and your patient had stable vital signs, you could obviously pursue further imaging. But when we start talking about doing CT imaging in a mass casualty incident, you end up with a significant bottleneck in radiology. And I'm going to talk a little bit about that once I show you some pictures. So this is the left upper quadrant. What do you see?
Looks like there's fluid above the spleen.
Mm-hmm, mm-hmm. Yeah, you've got fluid that's sort of tracking above the spleen, below the diaphragm, and then all the way around here. And this is the most sensitive location for free fluid in the left upper quadrant. And there's probably also just a smidge of fluid right here in between the spleen and the kidney, but it's probably a little bit echogenic because it's starting to clot. And here's a pelvic, or no, sorry, this is the subxiphoid view. Does this make anybody anxious?
Yes.
Yes.
Yes, we don't like this one. And then we move on to the pelvis. How do we feel about this pelvis?
Fluid as well.
Mm-hmm. And then here is your lung view.
Got a lung point.
Mm-hmm. Yeah, you got that lung point coming in right over here. So again, you know, in kiddos, I imagine you see a lung point and then you probably march it down the chest to see how far it goes. This may be someone who you can observe. This may not necessarily be someone that you need to intervene upon. But in looking through the literature at mass casualty response, also, it does seem like in general, physicians are probably a little bit more aggressive with interventions in situations like this. So this kid might get a chest tube, they might get a pigtail, or they might get a chest tube because you don't know when you're going to be able to circle back on that patient. Right. So when we think about what the challenges were in mass casualty events like Boston and Orlando, one of the biggest things that they talked about, which was a big challenge, was patient identification. And the reason this was challenging is because there were so many patients, obviously, that were coming in at a time. And they may have their naming conventions for anonymous patients or sort of unknown patients as they're coming in. But as they start to stack up in the hall, it becomes difficult to sort of clarify where people are. And we've gotten to the point now where we're so beholden to our medical record and sort of our computer system that if a patient is not physically where they say they are on the board, it's challenging to find them. I'm sure you all have had that experience where they say patients in one room and they're actually in a completely different room. So imagine the chaos when you have a bunch of folks who are not actually named by their names. So you can't ask them if that's their name, and you're trying to get imaging, medications, et cetera. Communication also becomes a real big challenge because you're dealing with a noisy situation, you're dealing with a noisy ER, you're also dealing with multiple different providers potentially engaging in the care of these patients. And so if you want to communicate to your nurses to give a medication or to take a patient to x-ray or to have x-ray come see the patient, you know, unless you have very good closed loop communication, that can definitely fall by the wayside. When it comes to interventions, again, if your patient needs to go to the OR, your patient needs a consultation from orthopedics for a fracture, or they need a consultation from a general surgeon or a vascular surgeon for a concern of an injury, having the imaging on hand to show them and the results on hand to show them when you have bottlenecks in radiology can be really challenging. But if you have your bedside ultrasound there to show them that there is indeed free fluid in the belly, the patient may not be responding appropriately to resuscitation, then they may be a candidate to go directly to the OR rather than to pursue further CT imaging. And then ultimately, there are significant challenges with flow. Now, I'm not here to tell you all how to run your disaster programs and your disaster responses in a mass casualty incident. There's an entirely different, field of emergency medicine for that. But when it comes to the ways in which we can use ultrasound in a meaningful way to guide consultation with our colleagues, to guide communication, I think there's some very interesting things we can do. To simplify things, making sure that there is a unified place for each patient where you can keep information like this. And this was in response to both Boston and Orlando. They recommended having an actual hard copy of a card on which you can physically write things. And they just used Sharpies because pencil, pen, whatever sort of disappears. And the card itself was almost like a card stock. So it would be a little bit more resilient to multiple people picking it up and using it. And that way, if a patient needed a re-intervention, the nurse called you because there was a change in vital signs or a change in status, you could go to the bedside, you could physically write on the thing what the next step there was in the patient's care, what needed to happen next, and what you found on your reevaluation. Particularly if you have a handheld ultrasound unit, then you can sort of stratify and direct patients appropriately to get the care that they need. Now, I'm not going to dive into this too much because Dr. Berant already did a great job talking about foreign bodies and fractures, as well as the concept of nerve blocks. But once the initial wave and even the secondary wave sort of settle down, you're going to get those patients who are more of the walking well, but may still have significant injuries like fractures or embedded foreign bodies. And the other thing is you may not have easy access to appropriate sedation and analgesics. And so using nerve blocks to facilitate the anesthesia of these patients in real time is probably going to be of significant interest. Don't forget about your quaternary and your tertiary survey. So once you've done your initial resuscitation and evaluation, going back to reassess everything. And as I said, I'm not going to cover nerve blocks, but I do want to show you some interesting pictures of stuff that's stuck underneath the skin. Have you all used the annotate version yet on Zoom? If you have not, I want to challenge you to try to do it now. So what I want you to do is find the button that says annotate. It looks like a pencil, or if you go to view more on your Zoom screen, it'll give you an option to sort of drop down and annotate. If you pick a stamp, then on the next screen, I'm going to have you show me the foreign body. All right. Excellent. Everybody's on it. All right. So what kind of foreign body do you think that is? What substance is that? I'm sorry, I didn't hear you.
Metal with reverb.
Good. Metal with reverberation. And do you think that we are in the transverse or the longitudinal axis to the metal?
Transverse.
Okay. Where is this foreign body? Good. All right. And is it, you guys know it's in the longitudinal plane. What about this one? This is like old hat for you all. Great. And this one? Any guesses for what this is? This is a delayed presentation, but this is a bullet that was underneath the patient's skin. What about here? This one's a little bit more subtle. I can't fool you guys. All right, and here? Any guesses for what this substance is? Say that again?
Wood.
Yeah, it's wood. And why did you say wood?
That's got a nice dense shadow.
Great. Excellent. All right, this is not a foreign body. What do you think of this?
Fracture.
Mm-hmm. Yeah. So if you find yourself in a situation, nice job, Josh. If you find yourself in a situation where you're backed up on your portable radiology and you need to assess whether or not the patient has a fracture, obviously, it sounds like you all are using this pretty frequently in your EDs anyway. So you're probably even better at fracture evaluation than I am. So I know that was relatively fast, but that's really all I have today. What questions or comments do you have?
Kat, that was great. I kind of curious, what units have you used or you think handhelds that you used that had good quality as well as worked well outdoors or in a busy environment like that?
Mm-hmm. So I have had experience with Butterfly, Lumify, the GE, and I think that for the purposes of mass casualty, they all would work. The nice thing about the Lumify and the Butterfly is they can attach to your phone. So they literally can be on the smallest handheld unit that there is. The GE is a little bit bigger and a little bit more clunky, and it's sort of like, it reminds me of an oversized flip phone because it sort of pops open and then pops closer. Like for those of you who are old school Trekkies, it's like a tricorder. It like pops open and you're like, and it's like ready to roll.
And that's the old V-Scan, right?
Mm-hmm. Mm-hmm.
So they actually came out with a new V-Scan Air.
Oh yeah.
That's actually nice. You should take a look at it or call your GE rep to have you. It's really nice. We had a demo about it the other day, and it was really, really much more improved. You know, for everyone, the old GE V-Scan was probably the first handheld, and the images were challenging at best. But they put a lot of money into this unit, and it looks excellent.
Mm-hmm. Yeah, I think the soft tissue resolution and procedural resolution for the Butterfly still needs some work. The Lumify has really, really nice visualization, particularly when you're in the nerve block setting. But again, I think in situations of extremis, a machine is what you need. I don't know that the specific brand is necessarily important.
Great, thank you.
Of course. Now, I think the only other thing that I would say, I was looking at your website for Cohen's Children's, and it looks like you all have a pretty robust disaster response and disaster sort of drills and whatnot. Do you mind sharing a little bit about what you all are doing and how you guys are drilling for pediatric mass casualty?
Matt, are you on the line? Might you be available to sort of give an overview? Thought I saw him.
What was your question, Matt?
Kat was asking about what our disaster preparedness drills and plan are like.
So I think like other large children's hospitals, we look at our capacity, which really shouldn't be time dependent. Sorry, you caught me at the end of a Peloton. So we at any point can typically take 5 to 7 critical patients and 15 to 20 moderate to walking wounded. We have an escalation policy that looks at utilizing resources from the adult emergency departments and the trauma services. And we just recently put into place sort of a system-wide pediatric code MCI. Actually having our first real test of this coming up in about a month.
Yeah, I think from reading through the after action reports from the disaster chiefs for any of these events, I think the thing that they really sort of highlighted as the benefits to the responses in Boston, the responses in Orlando, and even the responses in Vegas was that they have been drilling them and that their teams take the drills very seriously. And that this is the kind of thing you don't, if you don't practice it, you're not going to get good at it. And, you know, we hope that it never happens, but if you have at least practiced the skills, it comes much more cohesively when it actually goes down.
Kat, any pitfalls you would see with this using point of care and mass casualty?
So as far as pitfalls are concerned, I think making sure that there is a system in place for you to be able to communicate.
If there isn't one, that's okay, but you know.
Yeah, I think the biggest pitfall is being able to obviously archive the data. Nobody archives anything in a like a mass casualty. Like, you're not hitting the save button, right? You're not making sure that it goes up to QPath or whatever your cloud-based server is. And, you know, so I think ensuring that your team has a way to document in real time so that that document stays with the patient, I think is probably the biggest pitfall from reading through the experiences in Orlando, Boston, and Las Vegas. I think the other thing is just, again, trying to spend too much time focusing, right? I think that sometimes there are times when you should just do what you know. And, you know, it's a trauma resuscitation, you do what you know. The patient is unstable and there's no OR to go to, you give them blood. Like, you do what you need to do to stabilize the patient in that moment. You give them TXA, you know, whatever your trauma protocols are. You do what you need to do to stabilize the patient. And I mean, I'm saying that as someone who loves POCUS, and I use it, you know, every day, and I teach about it and everything. So I love POCUS, but sometimes you just need to do what's right for the patient. But definitely in those scenarios when you have a change in the patient's status, going back again to your ABCs and then going back to throwing an ultrasound probe on their chest, on their belly, is there a change? Like, maybe they had a slightly positive fast earlier and now their fast is much more positive, and they've got to change their vital signs, and you can feel more comfortable about giving them blood or calling the surgeon and saying, hey, you know, an hour ago, this kid only had blood in their pelvis and now they've got blood up around their liver and their spleen. You know, it's, I think that those would be the two pitfalls that come to mind for me.
Oh, great. Thanks, Kat.
Mm-hmm.
All right, I think we've come to an end. Thank you so much for joining us. And thank you everybody for joining us to listen to Kat's wisdom. This was a great talk. Thank you very much.
Thank you. Take care.
Okay, thanks.
Thanks, everybody.
Thank you.